Good morning, everyone. My name is Dr. MayKao, and I'm Vice President of Strategic Initiatives and the founding Dean of the Morrison Family College of Health at the University of St. Thomas. And it's my privilege to partner with Clifton Larson Allen and Fredrickson and Byron to put on these Future of Healthcare webinars together. It's also an honor to welcome all of you who have joined us for today's session to talk about a really important topic around how we actually advance solutions in health equity, particularly in medicine and in health delivery. So thank you for joining us. I'd just like to cover a few logistics before we start. This is the fourth in a series of 5 monthly webinars that we're delivering to replace our day-long Future of Healthcare conference, which some of you may have attended in the past. Our next webinar will be on Friday, March 12th, when we'll be welcoming Dr. Penny Wheeler, who is the CEO of Allina Health, and Mike Mikan, who is President and CEO of Bright Health. Together at that time, I'll be back actually facilitating to talk about how insurers and providers are coming together to drive innovation in the healthcare industry to meet the needs of patients and communities. Also, in a few business days, you'll be receiving an email with links to the recording from today's session, as well as any presentation decks. And then we'll also be pushing out a registration page for the March 12th session if you'd like to attend that. And then I wanted to run really quickly through the agenda today to share with you how the flow is going to actually occur. We're going to be, I will be turning it over to our presenters, Dr. Nathan Chomilo first, and then to Dr. Marc Gorelick. They'll be giving brief presentations. We'll go into a fireside chat, which is really just a conversation amongst the three of us. And then all of you are welcome to actually also use the chat function to type in any questions you'd like to direct to our two panelists, and I will facilitate those questions getting to them. So I'd like to actually do a brief presentation, just a little bit of background about who these wonderful leaders are in healthcare, and then I will turn it to Dr. Chomilo first. Our first presenter is Dr. Nathan Chomilo, and he is the medical director for the state of Minnesota's Medicaid and Minnesota Care programs, and practices as a general pediatrician and is in internal medicine. It is an internal medicine hospitalist with Park Nicollet Health Systems. His health advocacy work has been recognized by the city of Minneapolis, the Department of Civil Rights, which has recognized him as a 2019 History Maker at Home recipient. Our other presenter is Dr. Marc Gorelick. Dr. Gorelick is President and Chief Executive Officer of Children's Minnesota, the state's largest healthcare system dedicated to 100% to kids and teens. He joined Children's in March of 2017 as President and Chief Operating Officer, assuming his current CEO role in December of 2017. As a leader of an integrated pediatric health system, Marc strives to help Children's Minnesota fulfill its mission of improving the health of all children. So I'm really excited about hearing what they have to say about addressing disparities in health delivery and also advancing solutions to really dismantle racism and address some of the things that we see in society. I will turn it over to Dr. Chomilo first. Welcome.
Thank you, Dean Hong. So I'm glad to be here today. I'm going to give a kind of abbreviated version of a talk that is usually quite a bit longer, and so we'll kind of move fast, but hopefully we touch all the big points here. I start my talks for the last year plus now with a land acknowledgement, because I think it's important to begin by acknowledging the land on which I gather here in the Twin Cities is the seized territory of the Dakota people. And if we're talking about structural racism and health inequities, it's important to understand our history, and the Dakota people are still here with us today and still suffering from that land seizure, but still also finding ways to thrive. So we'll move fast. We're going to look really briefly at the different levels of racism, how medicine has historically and currently reinforced structural racism, how structural racism shows up in Minnesota, and COVID-19 has helped expose that, and then why a racial equity lens is critical to any sincere effort to reduce inequality and address equity. So racism is a loaded word, right? And usually when you hear it, these are the images that come to your mind, right? Charlottesville or the insurrection at the Capitol most recently. But really racism works in our lives in many different ways. And those images that associated with the word are really the tip of the iceberg. Those are those obvious obvious acts of bigotry and hate. Underneath the surface, racism acts in our lives in so many different ways. And so this gets to the different levels of racism. And so Dr. Kamara Jones, who's a physician and a public health researcher, former president of the American Public Health Association, over 20 years ago now really defined the different levels as institutionalized racism, personally mediated racism, internalized racism. I really recommend her TED Talk if you have not seen it, as she talks about her gardener's tale, walking you through those analogies. But for our purpose, I think it's good to just level set with definitions. And so racism being a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities. And then the reciprocal is it unfairly advantages other individuals and communities, and then saps the strength of the whole society through the waste of human resources. Similarly, when we talk about solutions, you've heard the phrase anti-racism. And so what does it look like? What are the definitions? So anti-racism from Dr. McKinney, someone I work with at the Department of Human Services, is a personal and collective identity which embraces the intentional dismantling of our racialized society and proactively builds racial peace. While anti-racist policy is defined by Dr. Ibrahim Kinde as any measure that produces or sustains racial equity between racial groups. So when it comes to medicine, it's really clear, again, to start with our history. And there's been no time, or as Dr. Evelyn Hammonds from Harvard says, there's never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built into our system. And medicine has played a role in that. And so back in the 1800s, prominent physicians were sought to look and find different peculiarities or differences between people based off of their skin color. And this was solely in an effort to justify the institutions of slavery and justify the institutions of land seizure. And so on the right there, you see ideas of how ones based on their race have different skull sizes, and that could give you ideas of their potential to do certain positions and have certain statuses within our society. Then on the left, you see an example of the many different repeated abuses of Black and Brown individuals in our communities by medicine. What you're seeing is a picture there of J. Marion Sims, who is the physician on the right, looking at an enslaved woman, Anarcha. And J. Marion Sims was previously felt to be one of the fathers of obstetrics and gynecology. He got that by developing a technique to correct a fistula that happened after childbirth between the vagina and bladder. He developed that technique by experimenting on his slaves without anesthesia at a time when anesthesia was the standard of care. And so the enslaved woman Anarcha was felt to have had at least 30 surgeries performed on her by J. Marion Sims without anesthesia. And you can see in the back, there's other women peeking behind the curtain. Anarcha was not the only one. There was many women that suffered at the hands of J. Marion Sims. And so this is all history that I was not taught in medical school, and it's really fundamental to how we understand how racism works in medicine today. We also know that, for a long time, Black and Brown students weren't allowed admission to medical schools. Once they started their own medical schools, they weren't allowed admission to institutions like the AMA, the American Medical Association, which was critical to get licensure and credentialing at many hospitals and clinics, so they couldn't even serve in their own communities. How we built our own hospitals is based in racist policy. The very act of our healthcare system being based in employer-based insurance is a method of structural racism, because who has the access to jobs with employer-based insurance? And then we can see the ramifications of our continued structural racism within medicine in COVID-19. And so if you look at Medicaid expansion of the ACA, on the left there, you're looking at a map from Kaiser Family Foundation that shows the dark blue states that have yet to accept the Medicaid expansion. On the right, you're looking at county level data from COVID-19 Atlas that's showing the rate of uninsured. And so the darker purple counties are high uninsured rates. Greater than 25% of people in those counties are uninsured. And so you see the correlation there. And I show this to kind of help you keep that eye of where we have not expanded Medicaid, for example, and where we are seeing COVID-19. So this was pre-surge in the fall, but you can see there's a pretty stark correlation between many of the areas of the country we have yet to expand care, and we're seeing some of the highest infection rates. And we know that access to care is really critical to fend off and manage many of the diseases that are comorbidities that complicate COVID-19. And then further, you see on the left a string of counties in the Southeast United States. This is called the Black Belt. And in these counties, greater than 40% of the population identify as Black or African American. And so you see that in this part of the country that holds a large number of our African American community, we have chosen to not expand access to healthcare. But you come up north and we have our own history. And so this is a map of Minneapolis on the left and St. Paul on the right. And this is a map of redlining, right? And so this is the institution that was started in the 1930s, the Federal Housing Administration. They were trying to identify what were going to be the viable areas or desirable areas to build housing, and then build rates around that, and the less desirable areas. And the less desirable areas in this map are red and yellow, and the more desirable are blue and green. And we know now that that was very much based off of the racial categories of the communities in those areas, much more so than the actual economic potential. And so we see the legacy of that today. So that map was from 1940. This is a map from 2016 done by the Minnesota Pollution Control Agency, where they are identifying areas at risk for environmental injustice. And so all the areas in green on this map are areas where the population is greater than 50% people of color in the Twin Cities. And again, so you can see the progression there, and hopefully you kept in your mind's eye what the yellow and red areas were. I'll just quickly bounce back. Red and yellow areas, green areas here in the Twin Cities today. We talk about environmental exposures, right, related to housing. This is a air pollution map, again by MPCA, that same area that we were just looking at. Darker purple is poor air quality, and you can see how that maps along those very communities we are looking at. And then last year, WCCO worked with Minnesota Compass to look at incidents of certain diseases in the Twin Cities that increase your risk of COVID-19. And so what you're looking at there is those areas that are red and yellow are areas where there are more higher prevalences of 3 to 7 of these risk factors: asthma, heart disease, kidney disease, diabetes, obesity, stroke. And again, we see how it very much aligns with how our communities have been structured by decisions we've made. And so in addition to structuring your life and your exposure to toxins, it actually structures your ability to have wealth and generational wealth. And so we zoom out for a bit and see that back in 2016, the average, the wealth gap between Black and white Americans was about 7 times, with white Americans having 7 times the wealth. And then if you control for certain factors, that actually increases. And you look at the median instead of just the average, that actually increases to about 10 times. White individuals in the US have 10 times the wealth. A lot of that based in housing, with a lot of the times housing being over 1/3 of one's wealth. We zoom back to Minnesota and we see how that impacts things like income, right? And we see a clear distinction between white, Asian, and non-white, non-Asian communities in the Twin Cities or in Minnesota when it comes to household income. You don't have access to the same type of housing and same opportunities that how housing is tied to education. It should be no surprise that then your access to bachelor's degree or higher levels of education are also disparate. And so we see those same patterns in Minnesota. And COVID-19 has shown us the continued economic impacts of these decisions, right? There's a phrase I've learned that with recessions, Black and brown folks are often the first fired and last hired. And we are seeing that play out again with COVID-19, with the percent of labor force filing for new or reactivated unemployment benefits disproportionately being Black and Indigenous individuals, and the percent of labor force filing for continued claims since the pandemic started in January of last year, being again predominantly Black and Indigenous individuals in our communities. So when you don't have access to wealth because your housing has been restricted and it's harder to get an education, it's harder to get a livable wage, you're more likely to lose your job or have a harder time finding a job after a recession. It's really no surprise then that we find that those communities suffer disproportionately from homelessness as well. And this has been a long-standing problem. This is data from Wilder that shows that since 2003, when they've been tracking it, we've had this persistent gap in homelessness. And we see that play out with COVID-19 as well. Again, disproportionate gaps. The top bar is our baseline demographics in Minnesota. The second bar is our demographics of homelessness in Minnesota. And the third bar is who's testing positive for COVID-19 amongst our homeless. And the blue and green bars there are our Black and Indigenous populations. And so I also want to touch a bit on how we get access to care, because that really fits in my role with Medicaid in particular. And so back in 2018, this would be kind of your pie chart of how most people get access to care, with that dark blue mostly being employer-based insurance, that light blue being Medicaid. But that doesn't tell the whole story. And so I actually had Lynn Blewett and her folks at SHADAC look at the data and give me the actual data on, based if you look at by community, who is getting access, or how they're getting access to care in Minnesota. And what we find is that Medicaid is disproportionately relied upon by different communities. So it's not just overrepresented in our enrollees, but if you look across the state, 44% of Black and African-American Minnesotans rely on Medicaid or Minnesota Care as their source of coverage, versus only 9% of white Minnesotans, for example. You can see the breakdowns there. And then when you look at children, it's even more notable. So 64% of Black children, 54% of Indigenous children, 52% of Latinx children rely on Medicaid, versus only 17% of white children. And so this illustration really kind of captures everything that we kind of quickly ran through, and more so about how structural racism is impacting and ravaging Black America and Blacks in Minnesota as well, whether it's housing, poverty, education, employment, access to healthcare, or we didn't even touch upon mass incarceration. All these things are contributing to health and the inequities we see. And so we really can't address equity if we don't address structural racism. And so this is my kind of standard equity versus equality slide. Again, remembering that equity isn't about giving everyone the same thing, it's about giving those who need more. So really, if you're trying to address equity, you should be asking yourself, are we applying a racial equity lens to all policies and decisions? Where and how do we not only expand, but also contract resources? So where are we building our buildings and clinics? What are we doing with our staff? Who are we training? Who are we advancing? Who are we retaining? How are we using quality outcome measures to measure that and drive our decisions? And then how do we continue to support access, and who is it designed for? So I've argued in several places about using a racial equity lens. This is something that we're doing more and more at DHS. And this, with every decision, looking at the data, asking what does it tell you about racial inequities that influence people's lives? What should be taken into consideration? What are the root causes or factors? How does the policy program or budget increase or decrease racial equity? How are you going to be held accountable to community, and what places community have in building those solutions with you? I really hope people, if you haven't heard of this report, check this out. It's the role of healthcare in eliminating health inequities in Minnesota, commissioned by Wilder and United States of Care, published last year, and really kind of tried to answer the question of how do we start to address health inequities and create a Minnesota where we don't have the racial health inequities you see now. And two key points from that is, one, inaction is not neutral, and hopefully you've seen through the course of this quick talk that inaction is really acceptance of an unjust status quo. And then I really like to point that we can't just look at ourselves as part of the solution. We have to be able to see how we are part of the problem. There's a systems transformation framework that gives you good ideas on an organizational level, community level, policy level, different levers you can pull. And I like to break it down this way. So we can look at ourselves as healthcare as a provider. for providing care. And so what are the trainings we're doing for our staff? How are we addressing structural racism within how we provide that care? How do we become more actively anti-racist? We're an employer. And so how do we increase diversity? How do we decrease wealth inequality, decrease racial inequity in wealth and access to wealth? How is healthcare an engaged and accountable community partner? So what are we doing to do sincere engagement where we actually share power and decision-making? We don't just go to community and say, we want to do this. What do you think? Why don't we start at the beginning and say, community, what solutions do you have? How could we help you lift those up? And as an advocate, this is something former Health Commissioner Ed Ellinger really talked about, health in all policy. And so healthcare is really involved in advocacy in many levels. And how do we bring our expertise to bear on decisions that are made that really do have a health impact, even if it's not directly in the HHS committees. And then I really want this group to be challenged, because I sat and watched the summer as many groups talked about their commitment to racial equity, their commitment to justice after the tragic murder of George Floyd. And I'm not the only one who's waiting to see what happens and what actually changes, because I've heard statements like this before. And so I think the COVID-19 vaccination process is one key place where we can really see this, as healthcare going to deliver on the promises they made this summer. And so as providers, are we developing and implementing allocation strategies for the vaccine that prioritize patients based not only on risks like age, but if they're a member of one of the communities that have been hardest hit by COVID-19, our Black, Indigenous, Hispanic, and Asian communities? Or working more directly with community organizations to bring shots to them, not just ask them to come to us? And are we using racial equity to drive our metrics? Unfortunately, a lot of our metrics have been entirely about speed and just getting it out, and speed favors a racist, unjust status quo. And so we need to find metrics and judge ourselves on those that drive racial equity. And then there's an opportunity to do it as employers too, working flexibility for vaccine appointments, potential side effect recovery. Target just recently announced that they're going to be doing paid leave for folks who are getting the shots. So how are the different levers as an employer we can really help encourage and make COVID-19 vaccine allocation and distribution more equitable? I'd like to end with my own path to becoming anti-racist. This is something that I didn't just roll out of bed one day and figure all out. It really was triggered in many ways by Philando Castile's murder, and I've continued to develop since then. And so, applying a racial equity lens to all my decisions that come across my desk, whether it's my role at DHS, my role as a pediatrician in the community, my role as a community leader in several organizations. Continue to advocate for anti-racism training, because we can't all be working towards the same goal if we don't have the same understanding, and then continue to examine my own biases. Here's a recommended reading list and tools, and I provided those slides, so hopefully those can be sent out later. And I like to end on this slide looking at, we can't just talk about implicit bias without talking about structural racism. And we have to be able to do both, because they're connected. And so we really need leaders with the courage to address racism, not just equity or social inequality. And I like to touch on that one piece of Dr. Kamara Jones' quote, that racism saps the strength of the whole society through the waste of human resources. Look forward to the chat, and thank you all for my time.
Thank you so much, Dr. Chomilo. That was a wonderful foundation for actually learning, and it's really fun to actually see the work and the report from United States of Care that we worked on at Wilder while I was still president there, actually get used to advance health equity. So I'm going to turn it over to Dr. Marc Gorelick, who, as a provider and as CEO of Children's Minnesota, has been doing what I would consider to be really groundbreaking work in actually applying some of the concepts that Dr. Chomilo has actually talked about. So Dr. Gorelick.
Yeah, thank you very much. Thanks for the opportunity, and thanks, Dr. Chomilo, for that great overview. I think that really set the stage for how we need to think as a healthcare system writ large about issues of equity and anti-racism. And what I want to focus on is more the healthcare system writ small. How does a healthcare provider like Children's Minnesota deal with some of all of these things that were just outlined? And I'll just start with my own background. My clinical background as a pediatric emergency medicine physician. So, I did that for almost 25 years before I moved full-time into leadership role. And, as a pediatric emergency medicine physician, I feel like I had a frontline seat to the disparities and inequities in society. And all of these things that we talk about, all of the disparities in health and well-being that we know to be true both nationally and especially in Minnesota are right there in front of you as a provider. And so I think that's sort of what has driven me to recognize the need to address this. And this is, as you just heard, this is something that we did not talk about in medical training 30 years ago, right? We've really come a long way in how we review race and racism as a factor. So, I alluded to this. We have tremendous disparities, racial disparities in all kinds of measures of well-being, such as poverty, education, housing, the things that you just saw, as well as specifically in measures of health, whether it's, infant mortality rates, maternal mortality rates, low birth rates, and so on. Huge gaps, racial gaps. And again, we happen to be a bit worse in Minnesota than in other places, but this is not a uniquely Minnesota problem. This is a national problem that we have. And, as we look into why is that the case, a lot of it is because of the disparities that we see in these social determinants of health. So we've come to recognize that a good chunk of our health outcomes are driven not by the healthcare we get, but by a whole variety of other environmental and social factors, collectively the social determinants of health. And you saw those: housing, education, wealth, and so on. And when you have the kind of disparities that you just saw in those social determinants, you're going to get differences in health outcomes. And as we've increasingly recognized that, we've come to recognize that we as a healthcare provider need to understand our role in addressing those disparities in health, in the social determinants. But we can't give ourselves a pass, right? We also have to recognize the ways in which there are inequities and systemic racism within healthcare that we provide, right? So that 20% is also subject to racial disparities and various forms of systemic and structural racism. And so we have a dual obligation, if we're going to make a difference, to recognize our role, in our case, Children's Minnesota, as a healthcare provider. How do we address the social determinants? How do we address what's happening within our own walls? And so I just want to talk a little bit about, what we're doing. And just to illustrate, so we know there are big differences in infant mortality, and it would be tempting to blame that on all the differences in access to healthcare, health insurance coverage, wealth, housing, et cetera. And that is clearly a contributing factor. But it remains true that the risk of preterm birth is higher, about twice as high for Black women as for white women. But Black women who graduated from college still have a higher risk of preterm birth than white women who dropped out of high school. So it is not just about those social factors, it's also about what we do. So let me just outline some of what we're addressing at Children's Minnesota as examples of some of the work we're doing. And we are still very early on this journey, and it is very incomplete. So on the social determinant side of things, we are a healthcare system. We're not a housing agency. We're not a jobs agency. We're not an educational institution, but we have a role to play in addressing those issues. And so we have a program we call Community Connect. We started this several years ago, and through this program, we work with patients coming into our primary care clinics to screen them for a variety of needs on those factors that may be affecting their children's health. And in the last year, we've served over 3,000 families with Community Connect. 39% screened positive for one or more of those social determinants of health, food insecurity being the most common, also housing, education, daycare, transportation, legal issues. And then we can do one of two things. In most cases, we work to connect those families that we've now identified. There's something that they have, one of these factors that is affecting their child's health, and connecting them with resources in the community who may be able to help address them, whether it's a food bank or enrollment in SNAP or WIC, as examples. In some cases, we can provide those services directly. So we have a health legal partnership where we have a lawyer in the clinic. So if a family says, I'm dealing with a potential eviction with a landlord, or I'm having trouble getting enrolled in in these programs for legal reasons, we can actually work with them directly in the clinic. And in the large majority of cases, we've been able to successfully connect families with resources that have helped address that need that we identified. And what we've shown is by doing that, we see that those families that are in this program, where we're addressing those social factors, have greater adherence to primary care down the road and reduced utilization of the emergency department, which is often the place where people end up when they're in a health crisis. So that's an example of the kind of program that health systems like Children's Minnesota and others are doing to figure out what is our role in addressing all of those disparities and inequities in those social factors that you heard so nicely outlined before. Then we've also got to turn an internal lens. As I said, we've got to focus on what are we doing to address systemic racism, racist policies, and the racist legacy that we have within healthcare. And so I think there's a few examples that I will give you. One is versus just acknowledging it, right? So we have started to explicitly look at some of our outcomes and breaking them down by race and ethnicity and including that in our quality reports. So when our board quality committee every month looks at how we're doing, that is one of the things we show as an equity dashboard. And it allows us to identify areas where we should be leaning in, develop strategies to try to address those disparities, and then follow our progress in it. So an example is we found, and this is not unique to Children's Minnesota, this has been well described nationally, children with painful conditions who come to the emergency department get pain medications less frequently than white children. So how do we address that? Well, first is we have to look at what is it? It's X% for the white children, it's a lower percent for the Black children. How do we close that gap? Training on implicit bias is one thing. Building in standardized processes for evaluating pain in all patients, and then tracking progress. And by doing that, we were able to close that gap so that we now have similar rates of pain medication being received for patients from different racial and ethnic groups who come in with similar conditions. But you have to shine a light on that, right? We'd love to say that, you know, sure, I read this article, it's a problem in Washington or a problem in Milwaukee or a problem in Chicago, but it's not a problem here. Yes, it's a problem here. So that's one thing. The second thing is we've started to look explicitly at racism as a form of emotional harm and how that contributes to patient safety. So health systems in general have recognized over the last 30 years that there's a fair amount of preventable harm that happens within the healthcare system. It was a groundbreaking report that came out in the 1990s that talked about the number of patients nationally who were harmed and in fact killed by preventable harm within our healthcare systems. And so we've shined a very bright light on figuring out how do we address preventable harm. One way we do that is by encouraging people to report those incidents. So if there's a medication error that has occurred, we encourage reporting of that so we can investigate why did that medication error happen? How do we prevent it from happening in the future? At Children's Minnesota, we implemented a new type of report specifically around episodes of dignity and respect. If a staff member either themselves is a victim of or witnesses either other staff or a patient family being treated in a way that is not consistent with dignity and respect. So racist behavior is a prime example. We have a mechanism for reporting that. And then we take those reports and we investigate them and we look for the root causes and we then are able to develop strategies for addressing them. And based on that reporting, this is now the fourth most common type of report that we see is these dignity and respect learning reports. We've now started to say, well, how do we address that? And one of the things that we've started to do on a pilot basis is using simulation training to help not only raise awareness of implicit bias. I mean, it's great to know that we have implicit biases, but we all do. That doesn't fix them. How do we then act on that information to overcome them? And so we're using simulation training as a way to work with our staff to be more equitable in their treatment of patients and families. And then the third thing that we're doing as a healthcare provider is recognizing that there is evidence that a more diverse healthcare team, a care team that better reflects the population we serve, is going to get better health outcomes. There's a study that was published, I think it was late last year. Actually, one of the co-authors was Dr. Rachel Hardiman, who's at the University of Minnesota. They looked at data from Florida, and what they found is that the Black babies had lower mortality in the hospital if they were cared for by a Black doctor. Other studies have shown similar findings. And I'm not trying to suggest that all patients should always be treated by a provider of their race, but it does suggest that a more diverse care team that is able to connect better and be more culturally competent and be more intentionally anti-racist is likely to deliver better healthcare outcomes. And so we are very much actively trying to improve the diversity and inclusiveness of our workplace so that we have a healthcare team that better reflects the communities that we serve. So those are some of the things that we're doing to address, this enormous problem in our system that Dr. Chomilo outlined, and how are we as a health system trying to address those factors and become a more anti-racist healthcare organization.
Thank you, Dr. Gorelick. Those were both wonderful comments. I love the background that Dr. Chomilo gave and about how we actually need to take responsibility as leaders for the outcomes that we're generating. And it sounds like you're doing that at Children's Minnesota, and that's a really important first step. I'm getting a lot of questions in the chat, actually, and I think we'll move into the fireside conversation where it's really a dialogue between you and me and Dr. Chomilo. But one of the things I've learned over time in advancing this type of work to really address racism structurally is that individual leaders and even organizational leaders, or even if you're the policy director over Medicaid, that it's often hard to find the right start for you to actually address systemic inequity. So I guess one of the questions I'd have for you is, have you seen that increasing racial representation amongst your ranks actually does work? And the other question related to that is, how do you as a leader actually stand up for and advance some of these changes in the face of opposition or resistance from the systems that you're a part of? So just about your own individual leadership, and have you seen that increasing workforce diversity actually does work? So why don't we go to Dr. Chomilo first, and then Dr. Gorelick.
Yeah, I mean, that's a good question. We know that you can't just give a seat at the table without power, and just have, because that's tokenization, and that's certainly something that we know doesn't work. And so, while being at the table and being able to bring the perspective and the lived experience is very helpful. Over time, if you aren't able to actually affect change, we will see the people who enter those positions to try and actually help improve them leave. And we've seen that with, there's been some recent higher profile incidences of Black women in academia and medicine in the last year leaving because they were brought and told that they were going to be given this ability to affect change, but then after the honeymoon period, it actually was turned against them, and they were seen as being too disruptive, right? And so I think there has to be some intentionality. It can't just be, we'll get all these folks with different perspectives at the table and things will work themselves out, because the systems are doing what they are designed to do, which is create these structurally inequitable outcomes. And so if you just leave it to the system to handle it without actually having some intentions and changing how things have been done before, you're going to churn through many of these people who do have the interest in kind of helping to move us on our journeys to address structural inequity and racism. And so it's kind of a both and. You can get that change, but you have to be able to actually be willing to do something a little different instead of just putting a Black person in a position to effectuate the same systems that a white person would.
Mm-hmm. Dr. Gorelick?
Yeah, no, I think that's right. I mean, I think certainly increasing representation, making sure that our workforce reflects the patients we serve is probably it's necessary, but not sufficient. We also need to if they're working, as you just heard, if they're working within the same system, we're not going to necessarily get a different result. So I think it's an important step, but it's certainly not the only step.
Mhm. What I've noticed happen to people of color in leadership positions, or just allies who are actually wanting to address racial equity in health systems and beyond, is that it's exactly what Dr. Chomilo said. You're hired to make a difference. When you start doing that, it starts rocking the boat, and there isn't really enough institutional support around the change process for that individual or those individuals to actually make the changes that are necessary to turn the system around. Since we're talking about solutions and ways to move forward, and part of that is obviously increasing representation, and then giving people the supports that they need in order to lead the changes inside the organization. Um, and COVID certainly during this time has highlighted the dual pandemics of racism and actually just COVID. What have you learned during this time about how we need to behave in your respective roles? How have you needed to behave? I mean, what insights have been gained? Maybe Dr. Gorelick, we'll start out with you. What strategies during this time have you really employed with some of the inequities that are actually we're seeing right now in society?
Yeah, so I think this is probably a great example of where, this is not about equality, it's about equity, right? So, so for example, we know we've got this new vaccine, right? People are evaluating it, they're trying to decide, am I going to take this vaccine or not? And, we have to recognize, acknowledge that we have globally, new disease, new vaccine, new process, there's going to be some skepticism. We also have to recognize that we have a long history of mistrust on the part of Black, Indigenous, and communities of color of the healthcare system around this very issue, right? Having been test subjects, you heard an example earlier about the surgery for the fistulas. There are so many examples of that, right? So there's a well-earned mistrust of the healthcare system. As we think about how do we engage with the community to help people understand the facts about the vaccine and try to increase the acceptance of it, we have to recognize that the needs of that are not going to be equal, right? We're in many of our communities, we're trying to address that in this background of why should I trust anything you tell me? So we have to recognize that, and we have to think about how are we going to approach different communities differently to make sure that we're getting the information across. And then we have to also recognize what the differential barriers are to potentially distributing this vaccine. So whether it's health insurance coverage, where people get their information from, where they get their health care, how they get their health care. And so the idea that we can just go out, say, great, we have a vaccine, it's approved, everybody take it, without really thinking in a very intentional way about how we have to address the concerns, the different concerns of different communities. And so, for example, we've, within our own institution, we've been doing varying degrees of outreach to, many of our employees of color who initially were having a greater degree of skepticism, again, because of this historical background. And how do we work with them to help them overcome that? And fortunately, we've seen, compared to other organizations, other healthcare organizations, we have had a higher uptake of vaccine, and a little bit, we do have racial disparities in that we're working to address, but they've been, I think, a little bit narrower because we've been more intentional about how we're approaching it.
Dr. Chomilo, same question for you in your broad policy role. What insights have you gained during COVID and about how racism works in decision making, just at what you've seen so far?
Yeah, I would say that COVID kind of accelerated some of the conversations, I anticipated having coming to the position with a focus on dismantling structural racism. And so that gave us the opportunity to then look at our policies, look at how we develop policy proposals, look at how we develop budgets, and really do the work of applying that racial equity lens. And so that means you look at the data you have, and if you don't have data, try to find it or improve the processes by which you gather it. As Dr. Gorelick has pointed out, you need to kind of have that data to make the decisions. And then really take a stock of what are who's going to be impacted by these decisions, right? And who's going to benefit, who's not. So often when we're looking at policies and budgets, we're looking at kind of spreadsheets and numbers and saying that, okay, we have to make the numbers work. And so we'll take this program and we'll invest here, but we'll cut this program here without actually taking stock of who are the communities that are behind those numbers. And I think when we look at budget cycles in particular, that's kind of a compounding impact, because often you'll make cuts to certain programs in times of deficit. And then when there's times of surplus, it's the programs that have the advocates that have the most money and time and resources and loudest voices who then get the reinvestment when and so we right now are working on a plan to at least track, if we have to make cuts, because that's our job as part stewards of these resources, we at least are going to hopefully track where and who is impacted by those decisions, so that when we have times of surplus, then we can kind of come back and say, what are the ways that we can kind of reinvest and make whole those communities that have historically not had that attention in the past. And so I think really that racial equity lens being a huge piece of navigating how do we really interrupt the cycle of structural racism and inequity that we see kind of repeat through our decisions and our budgets and our policies.
Mm-hmm. I have a question here from, I'm starting to turn to the questions in the chat, and there are a lot of them. So one of the questions from an audience member is, sometimes you're making these changes to advance solutions to decrease disparities in health, and then you're really seen as disruptive. You're just seen as disruptive, maybe, to the system. And disruption can be good or bad, but it usually needs cover so that you can actually make the change happen. What advice would you have for people who are trying to actually make this type of change? Having a racial equity lens in medicine or healthcare, or even in the community, how would you suggest going about doing that so you have enough longevity and cover to make those changes? How have you done it for yourselves, maybe even? Because there's always forces that are fighting against you. It's structural racism for a reason, because there's resistance. It's like pinging or bouncing back at you.
Yeah, I'll start by saying providing that kind of historical context and making sure everyone's on the same page as far as what you're working on, I think is important, and not hiding the difficulty that it will be, and that it will be an iterative process, that you're not going to get it right the first time, that these systems developed over 400 years. And so you're not going to be able to turn it around in a 1 year, 2 year budget cycle, 4 year election cycle, what have you. And so focusing on some early wins I think is really important, and kind of building from there. And then also really trying to engage with community early, because there are many in the community that want to see this work happen and will help support it, help you with ideas, as long as you're upfront with them about what their role can be, as long as you can share what power you're able to have. But I think having that kind of coalition behind it is really important, and not trying to see it as something that just you or just your organization has to do.
Mm-hmm. So generating some short-term wins, not doing it alone, those are really concrete strategies for advancing health equity in the ways that you know how. Dr. Gorelick?
Yeah, I think there's a couple of things. First is we have to strike the right balance, because short-term wins are really important. But I've also heard from people saying, well, you don't aim too low, right? Now that we've recognized, the more you peel back the onion, the more you realize just how deep and broad these inequities are. There's this pent-up demand to fix it all now. And so, and we're struggling with that. We're trying to strike the right balance. If we aim too high, we're setting ourselves up for failure. We're never going to fix all, even one of these things completely in a year or two planning cycle. But if we aim too small, to say, look, we got to make some start, it looks like we're not taking it seriously. So we're trying to strike that right balance of being aspirational but realistic. And it's a hard balance to strike, because, again, it's been building up for 400 years. There's a lot built up there. I think the other thing is, building in, and this is another one of the comments in here, is building in some degree of accountability, right? So because we have to, we can set these aspirational goals, but what are we doing to hold ourselves accountable for it? And I think one of the things that we've done at Children's is we've built a number of measures related to diversity, equity, and inclusion into our compensation plans for our leaders. So we not only set a goal for hiring of people of color, but we're judged on it by the end of the year. Our compensation is tied to whether or not we hit that goal. We set a goal around decreasing disparities in immunization rates. We have 300 people whose part of their pay is tied to whether or not we do that across the entire organization. So that's, one clearly, a mission-driven organization like Children's Minnesota, we're not there primarily for the pay, but it is one measure of accountability. And then we have to build in others. But I think, that's an important piece of it is, we need to demonstrate, as Dr. Chomilo said earlier, we've heard these statements before. What are we actually doing to deliver on it? And how are we making sure that people think that people within our organizations recognize that is an important goal? And that's one way to indicate importance, is tying consequences to it.
Mm-hmm. Yeah. So this setting goals, even if we don't always know how to meet them, just trying something, staying accountable for the results at the individual level and at the organizational level, at all levels of the organization. I mean, that's a way of making progress. I've also actually, the data is really compelling around disparities and just how that's been stacked up over time. I think sometimes when we're having these conversations, people think about this as just historical trauma, and they forget that it's actually still happening every day. So I thought I would move to the, as you see what's happening policy-wise or within your own organizations, what do you have frameworks? I mean, I had a question in here about frameworks that you've devised for how you operate and what you address and do. But I think people are looking for something really tangible and concrete. What are there frameworks that you think about in terms of how you operate, where you go, what you address at any given time?
The framework that we've really talked about with Minnesota Doctors for Health Equity talks about different levers that you can engage in the work. And so you can engage in health equity work and anti-racism work on the individual level, educating yourselves, educating those in your family, in your community, educating those in your immediate workspace. You really think about how you spend your own money, or even like what your 401k is doing. Is it reflecting your values? Is it investing in companies and corporations that do reflect your values? And then you can move from there to your kind of system level. So many of our systems, our healthcare systems now are much bigger. And so I think Dr. Gorelick's really kind of touched upon many of the great things systems can do, and physicians in particular are drivers of those systems. And so if they get together and really demand change, there's opportunity to have real dialogue and move the needle. And you look at community, and there's a lot of community organizations that have been doing this work for years, looking at trying to address health equity, yet haven't had the same level or profile because of the communities they serve and the way that we kind of structure opportunity and access to power and voice. And so what can you do to help engage in that work? Instead of reinventing the wheel and putting your name on it, how can you help bring power and access and resources to organizations that are doing the work and are really connected to the community? And then certainly there's kind of legislative or governmental advocacy, and how you can really have that conversation about how health does show up in education policy and transportation policy and criminal justice policy and all these other areas. And I think it's been kind of, as a culture, we've been kind of socialized to say talking about politics is bad. But that is actually our role as citizens, is to bring our own lived experience, professional experience to inform the dialogues that impact our communities. And I feel like if you're called to be a healer and impact the health of those you see in your clinic or hospital, it has to also, be reflected in how you engage with our broader community and structures as well.
Mm-hmm. Yeah, Dr. Gorelick, you identified a framework at the beginning with your introductory comments around what you're trying to do at Children's, redefining really the impact of, I think, disrespect and or what typically in the literature is called microaggressions, right, in the workplace that's impacting people. Are there other frameworks that you're employing at Children's in terms of decision making and advancing health equity?
Yeah, I think, one thing is, and again, there's a lot of work to do. We have 6,000 people here, right? So it's going to take time for this to permeate through. And, some organizations are going very broad, right? So they're implementing, say, implicit bias training across their organization. And we are rolling out more of that. But there's data that shows that training by itself doesn't actually deliver a lot of results. So that may be necessary, but it's not sufficient. The framework that we're trying to do is to say, how do we go deeper, but have it, but that's going to take more time to move throughout the organization. So what we've done is, as a senior leadership team, our 30 senior leaders have gone through a fairly intensive amount of, we've done the IDI together. We've gone through both group coaching, individual coaching. We've got peer group coaching that we're doing around anti-racism. And so what we're trying to do is to really have that really take solid root at that level so that we can then work to permeate that down through the rest of the organization. That's not the only thing, but I think that's an important adjunct, because if all we do is give everybody an hour of implicit bias training, which everybody gets a new employee orientation, that's not going to actually drive deep cultural change. And deep cultural change is much harder work, and it's going to take longer, but that's an investment that we've made to try to help to start that process of that deep cultural change by really working more deeply at least one level and then moving it down to additional levels later.
Mm-hmm. Yeah. So one way to go about this, and it's really what Dr. Chomilo finished off with his presentation, is we all have our own anti-racism journey. And just because you're a person of color, a white person, an indigenous person, doesn't mean that we have both been complicit in it, in whatever leadership roles we have or wherever we're leading. Seeing it and understanding what a racial equity lens is as a part of that initial journey. And while we're moving through it, of course, there'll be mistakes made, but that doesn't mean that we don't try it and we don't move things along. That's the main thing that I'm hearing from you. And I think the tie-in around personal leadership, teams actually adopting something and just trying it out. Everybody wants like a simple solution to dismantling racism. It's not simple. We're dismantling it in ourselves, in our organizations, in policies, and in the things that we've built over time. So, one lesson I'm taking from this is that if we're going to really address structural racism in healthcare, we have to start with our organizations and what we can control and leverage, and also using our power in ways that bring in community voices to balance the scale. So unfortunately, we're already at the end of our webinar. I would actually love to just continue this conversation, but in closing, I'd really like to thank both of you for your presentations and your time, as well as our partners, Clifton Larson Allen and Frederickson and Byron, for their continued support, through which we were able to actually bring important information like this outwards. I know that not everybody got their questions answered in this very short time, and I really thank you for participating. I hope you enjoyed today's session and learned something. In a few business days, you'll also receive the link to the recording of today's session, the presentation deck, and the registration for our next webinar, which will be on Friday, March 12th, with Dr. Penny Wheeler and Mike Mikan to talk about payment and provider reform, and also innovations in that particular space so that we can maybe have more holistic systems of finance and actually patient care. Our March session will return to usual at 8 a.m. for the start time. And if you're looking for any additional professional development, please check our executive education website. We have ongoing opportunities for learning. And thank you so much for joining the Morrison family of College of Health, the Opus College of Business, and the University of St. Thomas overall with this session. Thank you so much. Be safe and be well.